Welcome back to session number 3 of day 2 of TIO Global 2026. And now we're going to present and discuss a recorded case demonstration of the treatment of pulmonary embolism. And I'll do that with a star faculty. First of all, I'd like to introduce my very good friend, my dear friend, Dr. Amir Kaki from Detroit. I also would like to introduce Aleksander Araszkiewicz from Poznan, Karl Fengler from Leipzig, Dmitry Sulimov from Leipzig, and then as a case presenter, Dr. Pablo Salinas Sanguino, who will present from the hospital Clínico San Carlos in Madrid. As you know, pulmonary embolism is one of the most time-critical emergencies in cardiovascular medicine. And we have had several trials recently that have opened up the treatment armamentarium of patients with pulmonary embolism. So Pablo, we hand it over to you and walk us through a case demonstration that you did in Madrid.
So if I can have my presentation,
yeah.
What I did was to put together 2-3 cases to maximize the educational value of the presentation. These are my disclosures. And I am presenting this system, which is not a single catheter, but a system. So FlowTriever basically provides a paper procedure scheme where you will have a sheath. So Entry 24 is a 24 French sheath dedicated to the system. We will have 4 different catheters available, different curves, but also different sizes, diameters. We will have the flow saver, critical part, to filter the blood and be able to return to the patient, so we can have full procedures with less than 100 cc's of blood loss. And then some nitinol tools. Probably this is the original name of the system. FlowTriever was this kind of disc system, but now it has evolved a lot, and now 90% of the procedures are being done just with catheters, no nitinol, no nothing. So this is the checklist of the material that you need to be able to have in your cath lab beyond the FlowTriever system. It's very simple. You will just have to find an Amplas extra stiff wire or any wire with very short floppy tip, because stability is crucial. This is an over-the-wire system, and then a couple of catheters. A long 125 multi-purpose catheter is super useful, and then a curved pigtail is what I use to navigate and to do angiograms, but you can also use a balloon tip catheter such as Swan guns. This is the basic case that I want to present. This is a 69-year-old female with that presents to the emergency department with syncope and head trauma. She had prior DVT. She's got an intermediate high risk PE in the European Society of Cardiology classification with some desaturation, blood pressure 110, heart rate 115, so shock index a little bit over 1. Troponin positive, D-dimer positive, lactate positive 3.3, and also an RV-LV over 1. It was actually 1.7. She was referred from the acute cardiac care unit, and if you can have a look at the CT, you will see that there's a lot of trauma there, subtle P actually. So this is the way that we decide over these intermediate to high-risk patients. Maybe now with the high PETO and the ongoing trials, we will have to revise this criteria. But basically, at my institution, what we do is we take patients on the higher end of the spectrum of the intermediate high risk. So we select patients which have lactate over 3.3 or shock index over 1 or syncope. These are the primary criteria, any of those, or we also individualize based on the secondary items that you can see below. So desaturation, proximal DVT, oliguria, and organ failure of some kind, or just lactate positive at the level of being just beyond your upper reference level. So this patient was selected for intervention, and this is something that we are currently doing. We are not no longer doing angiograms in the studies. What we are doing is working with the CTs, and you can just with the MPRs look at the projections that you are going to need, and you can have very similar findings on the angiogram. So we are no longer doing baseline angiograms. They will be the right pulmonary artery as it was simulated in the CT, and also in the angiogram here just for educational purposes. Also, you can use any kind of advanced CT tools. For example, this is Trimensio, and also you can use Trimensio to make a simulation of the angiogram you are going to find. I think it's important to understand and to learn more about the baseline CTs. For starters, you need a vascular access echo-guided. This is nothing new, but very critical in terms of safety, that you don't puncture a vein that is thrombosed. You can make some mistakes over there. We usually just use an 8 French sheath, and we check ACT, and then if you are unsure, what you can do is to do angiogram. So you can do, for example, this case have thrombus at the right iliac vein, so we went to the left, and we did an angiogram to check if there was remaining thrombus, because you could decide to aspirate this thrombus from the beginning, from the entry sheath. Okay, so you can. This is optional, but this is something that in some cases is useful. Then we still use a vascular closure. We still use prostyle just because I want to finish the procedure in the cath lab and take less post-procedural care, but the system also provides an ancillary tool for doing the figure of 8 closure, or you could just compress. It's a 24 French catheter, but it's very easy with the vein. Then we use the entry. The entry is very easy to prepare. You just flush the central line, and then you flush the side, and there is a very nice dilator with very flat transition, so you don't need any intermediate dilators. It is nothing wrong about using several dilators, but you don't need that. What I usually do is I use a high support wire to advance the catheter, so everything goes smooth. So I take a little bit of care with the access. I know it's not an artery, but especially in obese patients, this can be a little bit tricky. So I want to play it safe, and whenever it's in position, you just take the dilator, and then you are ready to go. This could be like a basic procedure. So first thing is to close the tricuspid valve. You can use a Swangans, but you can also very easily navigate a pigtail. The purpose of using a big catheter is to go central in the tricuspid valve. This is an old case. That's why I'm using angiograms. But I want you to show them, to see them for educational purposes. This would be LAO 30 for the left. You can see some coughing related to the angiogram. And then you go to the right. And it's very important to start from the right side. It's much easier. And we always start from the right side unless there is just unilateral PE that also can be possible. So we do some basic hemodynamic readings there. And then I usually use the multipurpose to go very distal, very far with the wire. Then we prep the T24, and it is routine to start with the T24, okay? Unless the patient is very, very small, you can consider using the T20. You see that this is a over-the-wire procedure, so wire stays in place and the catheter goes in, and the only thing you cannot do at this point is to advance the catheter without the dilator. I'm taking the dilator out and I'm aspirating. It's very simple. You just pull the syringe, you close, and again, for educational purposes, I'm showing how this was maybe 1-2 years ago. So you just took the content of the syringe, and frequently you will have a lot of thrombi over there, okay? We are no longer doing this. We are filtering the blood and returning the blood, but I think this is very visual. Then usually when the thrombus stops coming, you will do an angiogram. And to do the angiogram, you load the catheter with 15 cc's of contrast, and then you push with another bolus of saline. In this case, there was remaining thrombi, so we put the dilator in again to advance for the most distal lower lobe, okay? And then we start aspirating again. This is typical situation where some blood is coming, but the syringe is not filling completely. So then, first thing that you need to know is that you need to wait. Sometimes the thrombus is elongating and it will get into the catheter, but in some time, maybe 30 seconds, and then you pull back the catheter and then you make a space and sometimes flow, and then you get the thrombus out. Whenever you are ready, you go back with the catheter to the main pulmonary artery, you send a floppy wire to the other side, you recover your stiff wire from the right, and then you navigate distally with the multipurpose or the floppy wire, and you exchange for the stiff wire, and then you are ready to work in the left pulmonary artery. With a T20 curve, we are now, in every case, going with this system, unless the thrombus is very, very proximal. This will be the flow saver drill. You filter the blood. You are loading the blood in a 50 cc syringe on the left, and you are disposing of the thrombi. This syringe is going back to the patient through the sheath. In this case, it was a gore dry seal, but frequently it will be your entry sheath, okay? And this is safe, and it has been tested for several hematological tests that this is safe enough to be returned to the patient. This would be the T20 curve, which is relevant for the left pulmonary artery. You can see that there is some thrombi over there at the inner curvature. This is very difficult to reach with the T24. It is a little bit stiff. So what we are doing here is to put the wire in a better oriented branch, and then we are introducing the T20 curve. Okay, and then you play with the distance from the tip of the T20 curve to the tip of the T24. So if they are too close, you will not have a curve. And you can see now that we are orienting the catheter to the thrombi. This would be an aerial view, and we are aspirating from the most distal part, okay? The T20, and you can also double aspirate from the T20 plus the T24, okay? We clean this artery for this particular case. This is a different case from the first one, okay? Next thing that I want to show you is just the hemostasis and the of procedure. You will see this kind of thrombi. This is the flow stasis, so it's an ancillary tool for a figure of 8. And this is the typical amount of thrombus that you can recover from a case like this. This is very visual, but the most important things are the vitals. So we are looking for a drop in heart rate, a raise in systemic blood pressure, and a pulmonary artery pressure drop. Okay, in this case, we got a 5 millimeter pulmonary artery pressure drop and a 30 millimeters systemic blood pressure rise. This patient was discharged at day 4. Okay, so some tips and tricks for maybe your first cases if you're not so experienced. Something that is frequent is the lollipop. So lollipop means that nothing is coming back. What you need to do is to bring everything back. In this case, with a T20 curve and a T24, we are aspirated from both sides and nothing is coming back. So what you need to do is to pull back your catheter up to the entry tip. Then you can do an angiogram through the entry, and you will see that there is this lollipop, means that there is thrombi at the tip of the catheters. And you really need to externalize this, and there is a risk of re-embolization here. So what we are doing here is to put a third syringe to aspirate from the entry, and we are expecting that two things might happen. We can either got the thrombi in when we are pulling back through the entry, or it can be at the patient's skin, okay? And maybe if you don't do this properly, or if you are a little bit unlucky, you might re-embolize this thrombi, and this is a risk that pertains to this procedure, and we all need to know this and be aware that we might be having a brisk deterioration of the patient if re-embolization happens, which is very much not frequently found, but we must know that this might happen. This other case, you can see that there is different aspect of this angiogram. It didn't came out from the entry, but we externalized. So sometimes you pull everything back, and the thrombi will be at the skin at the entry point. Okay, so we are pulling back the thrombi here. You cannot see this very clearly in this picture, but the wire is still in. So my distal wire is still at the lungs. And this is very important to get back in case we need to go and still keep aspirating, which is often the case. Okay, this is called lollipop. It happens, maybe it's 10% of the cases or 20% of the cases. It depends on the amount of thrombi that you can find in the lungs. And also it also relates to the age of the thrombi. So the thrombi that is very well organized, maybe a DVT that is been in the leg for maybe 10 days, 2 weeks, it's going to be hard and very difficult to elongate and get into the catheter. Okay, some final tips and tricks. So go very distal. So invest a little bit on the optimal wire position. I see some people doing this minor mistake of trying to go very fast or take a shortcut. So go aim for the A9, A10, never go to A4, A5, A6, because you will have poor support. And some perforations have been reported on this area. So always go to the lower lobes. I always tell my fellows, my colleagues, to try to go beyond the diaphragm. This is very good position of the wire, for example, and the catheter is going very smoothly. This is another example where we fought for a very distal position of the wire, and the catheter will just go in smoothly. Okay, some patients will feel some chest discomfort at this point. This is due to the stretching of the heart chambers. It's okay, you don't push, you wait, and you go slowly. Finally, some other things about catheters. You can telescope the T16 for the most distal parts, and also for increased support. Some cases where you have low support, you can use both catheters with a mother and child system, and this will help navigate some tortuosity at the heart. Okay. And this is the only case where you can actually advance the T24 without a dilator, and that is because you have the T16 and you are doing this mother and child. This was of help in this particular case for overcoming some support issues. Also, to go to the most distal areas, this is a segmental thrombi that we could not reach with the T24, and we advanced the T16, and we safely recovered this area. Sometimes also T16 goes well to the superior lobe of the right lung. Also, you can use double wiring to manage bifurcation. You already saw this aerial view of the left lung to go for a more anterior artery. Usually you have 2 or 3 branches here, one more anterior, one intermediate, one posterior. And sometimes you are not getting the thrombus back in, and this just it's because of the wire is not oriented. And also I use this frequently to get to the truncus anterior or the upper left lung. In this case, this is parallel wiring, one stability wire on the lower lobe, and in parallel I am advancing at T16. There's enough room for both systems. In conclusion, and I'll be happy to answer your questions, in my personal perspective, I think that one relevant issue that Flow Trigger brought us was procedural reproducibility. You will have assistance from the company, and you can be proctor as well. So this is kind of the system that we changed from coronary to structural heart disease, where you are told by the company how to use the device, and if we all do the same, we can get reproducible results. Second thing, let's say your basic learning course. This is a frequently asked question. It's probably not very long. It's 5 cases. 80% of the procedures, it will be T24, T20 curve plus flow saver, but please don't take shortcuts. You cannot do this procedure in 20 minutes. You need to take time and to be careful because these are big catheters, and you really want to keep the wire in position and think about safety and be systematic. Third thing is about taking one step forward, so intermediate level, maybe 5 more cases. In 10 cases, I think you are more or less independent and proficient. And in these cases, you will probably play with this mother and child system. You will use several wires to manage the bifurcations and to go to the most distal segments. And you can also start using the nitinol retrievers for the most resistant thrombi, which is basically a basket. kind of a Fogarty procedure, and then discs that are less and less used. This would be for a very, very proximal occlusion. And finally, there are advanced procedures or many more things that you can do. You can engage in high-risk procedures that technically are basically the same, but obviously you need to react and to take care of the shock as well. You can do combined procedures with ECMO, which perfectly fits. The only caveat is to avoid aspirating of air into the system. So whenever you open the valve to the outside of the body, you need to clamp the ECMO or to lower the revolutions. Also, you will work in clotting transit cases, so you will start aspirating maybe in the right atrium or other areas. And finally, there are off-label procedures that can be done with the system. For example, for right heart endocarditis, I have performed a few of these. This is all that I wanted to share, and I think we are gonna get more and more used to this procedure as well. So I'm happy to hear your questions at this moment. Thank you.
Thank you very much, Pablo. Well, you clearly demonstrated that you do need some skills with the use of large bore vasculotomy and large bore devices. So then the question is, yeah, who's trained for these kind of procedures? And this is always like a balance between interventionalists and radiologists, maybe sometimes a surgeon. So how is it in Poznan? Who's doing these procedures? Is it all the field, the workspace of the interventional cardiologist, or is there more like a friction between radiologists and cardiologists going on? Alex, how is it there?
Yeah, in Poznan, generally, these procedures are performed by interventional cardiologists, and this is not because interventional reasons, but because the pulmonary embolism response team is based mostly on cardiologists, because this is not a problem of intervention, but also the problem of qualification of patients to these procedures. Pablo, I liked your criteria very much. In Poznan, we also perform echocardiography, and we evaluating, and also in CTPA we are evaluating RV strain, which we found it is very important to have RV-LV ratio more than 1 or even 1.5. And this is also very important criteria for us to qualify the patient for this procedure. And of course, in Poland, generally, we have new subspecialty in interventional cardiology, let's say pulmonary circulation subspecialty, because the anatomy and also physiology of pulmonary circulation is a little bit different in comparison to systemic circulation. And we had some experiences in BPA, bone pulmonary angiography, in CTPH, so we knew quite well the anatomy and physiology of pulmonary circulation, and it was much easier to start performing these procedures in pulmonary embolism.
Okay, so Pablo, I was intrigued by one of your comments. You mentioned that you no longer do these. You no longer use angiography during the procedure. But how do you monitor then the effect? Is it just based on hemodynamics? How do you do it then? Hemodynamics and oxygen saturation, is that the way to monitor?
Yeah, to get things right, what I'm not doing is baseline angiography. I do use angiography to control for the final result of a specific artery.
Oh, okay.
But doing baseline angiographies can be overcome with a proper study and simulation of the CT. So provided the CT is close enough to the procedure, usually it will be 24 hours or 48 hours. So basically the thrombi will still be there whenever it was wherever it was found in the CT. So I don't use it for baseline, but whenever I stop, whenever the thrombi is stopped coming out, then I do a control angiogram, and this is still useful. but it saves contrast. So instead of doing, we went from around 200 cc's of contrast per procedure, and now we are using less than 100. So it's about procedure efficiency as well. Programs are not so well tolerated as well. Not doing baseline, but yes, after cleaning one artery, you need some angiographic feedback, because some branches can be difficult to reach, and this belongs to the position of the wire. So you have a wire bias, basically, because this is an over-the-wire procedure, and changing the wire can go very fast to the thrombi. So yes, you still need some contrast.
Yeah. So in the last 1 year or so, we had multiple randomized controlled studies on this topic with different devices. We have the recent HI-PITO randomized study that was presented at ACC, but we also have Peerless. And the interesting part was that HI-PITO was comparing the ecosystem in context of patients at high intermediate risk pulmonary embolism versus standard of care, which was anticoagulation. But in Peerless, we were comparing the Inari system with the ecosystem. Dmitry, do you want to comment on that? And what is your take after these two randomized controlled studies? Do we have now multiple technologies that we're still using, or has the field already progressed to pulmonary embolectomy?
Thank you for the question. It's quite a difficult question. I think we have a big field of different devices we can use. And I think the future will be individual approach for each patient, depending on severity of disease, depending of hemodynamic conditions, depending of maybe skills of the individual operator and time from beginning of symptoms. From our own experience, we have some experience with such patients where the symptom begins more than 1 or 2 weeks. And it's quite difficult to perform embolectomy using Inari system, but also such patient with old thrombi, old emboli in pulmonary circulation, they benefit from local thrombolysis with Inari or with ecosystem or with conventional selective thrombolysis catheter with older thrombi.
Yeah. So Karl, you are offering both therapies then in Leipzig, and is there then is that the cutoff? Is it thrombus older than a week or older than 2 weeks? That would be then more shifting towards echo-guided thrombolytic or ultrasound-guided thrombolytic therapy, or and the younger, the fresher thrombus, that is the domain of the Inari system of embolectomy. What is your stand on that?
It's a bit like that, actually, but what we also frequently see is cases with recurrent thrombi, so you have old and newer material in the same patient. The case like the one we've seen right before with the central settled thrombus, that's of course the case for thrombectomy, at least to me. But if you've got the more disseminated thrombus or even an older thrombus that favors thrombolysis, sometimes you also combine both procedures in one patient. I think it's an individual decision right now. Despite the Peerless trial, it doesn't help too much, quite frankly, in this situation.
Yeah. Does it often happen that you combine both? That you first start with the echos and then convert to an Inari kind of strategy? I've never done it, but is this in Leipzig from time to time the case?
We do these cases from time to time, but the other way around. We usually start up with thrombectomy, and if we don't succeed, or if we see an endless procedure, very, very immobile thrombus, very disseminated into various segments, then we might add a local fibrinolytic. Yeah.
Oh, I like that strategy. And how do you then deal with the access? Because obviously your access is then problematic.
Yeah, you need an extra access. Brachial vein, jugular vein. We've done, I think, one case imagery together with the original sheet. We would not recommend doing that because we've had a massive thrombus there then. So you need an extra access.
Yeah.
But it's more about...
Alex, what is your what is the typical follow-up of those patients? Do all these patients undergo CT follow-up at one point? Or is this only when it's clinically indicated, when they remain symptomatic? What is your practice there?
Yes, they usually this is based on clinical criteria, and the routine CT is not needed. It's not necessary because usually maybe 70 to 80% of patients has on table improvement, and we know that even if we have some residual thrombi inside pulmonary arteries, it is not an indication to do nothing with this thrombi. The patient is improving, and this is the most important thing. But of course, in some patient, if we are not sure, do we have the reload of thrombi or something like that, or deterioration of patient, we can perform CTPA. And mostly our decisions are based on echocardiography and clinical criteria. And I'd like to mention that there was also the third randomized control trial with another device, penumbra device, Flash, Storm PE, which was published last year at TCT. So we have 3 big randomized control trials in the area of interventional treatment of PE.
Yeah, so it's clear that this field is definitely moving forward, and that probably guidelines will follow in the near future. Maybe then some more practical tips. Already Pablo mentioned several very useful tips and tricks in his case presentation. But Dmitry, for people who are starting up their experience, what would be, for instance, the angiographic projections that they would need to use for a right and a left pulmonary embolectomy? Do you have like some tips there? Is there like a standard? What is your practice there?
We are trying to do procedure as simple as possible. We usually work in the anterior projection, and we are very happy with our angio series because we have deep left angio series, and the second one is 90-degree LO. We can change it for 50, maybe 40 LO, and combine LO and anterior projection.
Okay, and that for both vessels, doesn't matter for left or right pulmonary artery?
Yes.
Yeah.
For right,
okay.
Rather left, and for left, rather right oblique projection, 30 or 40.
So that would be yours. So if you have a right pulmonary...
Yeah, sorry.
So let's briefly continue on that, because we need to be practical. So Alex, if you have a thrombus in the right pulmonary artery, you use an LAO 40. Is that what you're saying?
Mostly, and the most basic projection is AP projection, and 80% of my procedures I perform using only AP projection. But if I want to see more clearly where I am, I can use I usually use 30 or 40 degree RAO for left pulmonary artery, and LAO for right pulmonary artery. If I want to see, because I'm not sure are there any more thrombi somewhere there, but 80% of my procedures I perform with the use of AP projection, just normal anterior posterior projection.
Yeah. Okay, Pablo, some final comments from you?
Well, I will maybe make the comment about the device selection. So we have to take into account the bleeding risk of the patient. For example, in high peito and as well in Peerless 1, sorry. All the patients included were basically free from any contraindication for lytics, either absolute or relative. So if we are in a situation where the patient has very low bleeding risk, I think you can maybe choose, depending on local factors, experience, anatomy, and so on. But if the patient has a high bleeding risk, I think probably FlowTriever needs no lytics, and it's a little bit more polyvalent. We have even performed this in patients with overt bleeding, doing very quick procedures with very low dose of heparin, and then in the very same procedure, insert a cava vein filter from the groin for those patients with contraindications for anticoagulation. So bleeding risk is something that we also have to take into account.
Okay, guys, thank you very much for a very informative session. I think we shared tips and tricks related to the practice of pulmonary embolectomy, and we saw a very educational recorded case from Madrid. With that, I would like to thank the panelists. I would like to thank Pablo and also thank the audience. Stay tuned during TIO 2026, the global version, because we have another session where we'll discuss pulmonary ectomy later today. So thank you for your attention, and now let's move to session 2.4, where I'll hand over to Azim Lateeb to chair our next live case. Over to you.